Well, hello everyone. Great to see you, and many thanks for your interest in this clinical practice guideline for physical therapy management of older adults with hip fracture. My name is Morten Tange Christensen, and it's a great pleasure for me on behalf of the author group with Tom Herring, Christine McDonough, Marcy Harris-Hayes, Kate Mangione, and Jan Overgaard to welcome you to this 30-minute Q&A live webinar. The webinar is a collaboration between the Physiotherapy Special Interest Group of the Fragility Fracture Network and the American Physical Therapy Association and their sections of orthopedics and geriatrics. And if not already a member, I hope that you use the opportunity to join the FFN network, and of course also the Physio-SIG group, which I'm the co-lead of together with Professor Katie Sherrington. So I also hope that you had the time to look at the guideline and to watch the on-demand videos by the authors. And we look very much forward to hear your comments and answer your questions. So please click on the Q&A box to write your questions and write any comments in the chat. The webinar will be recorded and later on available on the Physio-SIG YouTube channel together with the on-demand videos. So, and with that, I will hand over to Christine, who will be the moderator of this webinar. Thank you.
Somebody has to be on mute to start the day. Thank you, Morten. Welcome, everybody. So what we thought, first of all, as Morten mentioned, you'll put your questions in the Q&A section, and we will address the questions by the panel. To start with, we wanted to begin by bringing up some questions that we received in response to the release of the clinical practice guideline via social media. And so to start with, I want to start with you, Morten. There was a question about the timing of first assisted transfer and ambulation. And this was a pretty specific question getting at sort of how to record the time and when do you start and how to think about this particular question talked about starting the time from the end of surgery or the beginning or what. So could you just kind of address that? And you're on mute.
Okay, so that's better now. So yeah, it's a good question, and it's one of those that came up ahead of this webinar based on the guideline. And we actually have this strong recommendation for clinicians to assist patients in getting out of bed and ambulate as soon as possible after surgery, if not contraindicated. And then we also write that you should record how long time from surgery to first transfer and ambulation. But we don't really specify when is it when the commencement of surgery, or is it at time of closure? And we don't really have a specific timeline for that. But if we look at the national registries, one of the largest, the UK, we also have from Denmark, Ireland, and Australia, New Zealand. They all have mobilization within the day after surgery as one of their focus indicators. And I think that would be the right answer to that. If possible, you can mobilize your patients on the day of surgery, but otherwise it should be at the latest day after surgery, if not contraindicated. And the reason for saying that is that there's a quite strong evidence related to that based on these national registries that show that patients not mobilized on the day after surgery at the latest, it was associated with severe events such as mortality, increased mortality, And it was also those mobilized had better mobility outcome and were discharged earlier than those not able to be mobilized. So I think we would say it's within the day of surgery or at the latest the day after surgery would be the recommendation related to that question.
Thank you. I see we have one question by M. Geerlings, and I'm going to get to that one after we do these other two social media ones. So everyone else, please pop your questions in while we're discussing these ones. The next question came on social media, and it was about having not seen so much in the guideline about nutrition. And I think I may take that one in Tom's stead because Tom is, I think, commuting to the Zoom location. And what I would say about that is we really appreciated the feedback on a couple of areas that are really central to management of people with hip fracture and yet aren't the focus of this particular clinical practice guideline. The scope of this guideline was really on the central interventions of physical therapists. We do mention in a couple of areas, for example, in skin condition and a few other areas, the importance of nutrition, although we do not make specific recommendations around nutrition for physical therapist practice. In the interprofessional recommendations, we essentially recommend that physical therapists participate in all interprofessional management approaches for delirium and for skin, including nutrition. But we acknowledge the importance of nutrition, and one of the things that we are doing right now with the feedback that you all are giving is bringing that feedback in for our plans for an update or revision when we next update the CPG to see what kinds of topics could be at least alluded to a little bit more specifically, such as nutrition. And anything to add, panelists?
I just want to concur with Christine with this whole interdisciplinary management, which I think is just such an important piece of hip fracture management on the whole. It really is more than just physical therapy. Even though the guideline is for physical therapists, it really does. The best outcomes seem to be when you have the entire team involved from the very beginning.
Yep. Thank you. And then the last one that we had on social media is very similar. And again, I think I might be taking that one for Tom. And it was in regard to vestibular management of identification and management of vestibular disorders for people with hip fracture. And what we certainly found, we did mention many times, as this person noted, balance issues and the management of potential balance and gait disorders without going into detail on vestibular management. And that was, again, partly because this clinical practice guideline, it was outside of the scope to focus on vestibular problems, but it is an important topic, and we have based on this feedback thought about the fact that it may be that there are clinicians who are managing individuals with hip fracture who maybe aren't experts in vestibular disorders and their treatment, and so. First of all, we would like to point to existing clinical practice guidelines for vestibular care. And so it's a topic that we will definitely bring forward for the next revision/update to consider how we can be a little bit more specific about vestibular disorders without expanding the scope of the CPG too much. And again, without duplicating efforts. So our goal would be to point to another existing best practice clinical practice guidelines for vestibular interventions. Any comments, team?
Morton, I wonder, I know in our work of hip, and I've looked at hundreds and hundreds of hip fracture records over the years in all of my studies with hip fracture, and I would say that I do not see a lot of patients talking about dizziness prior to the fall. There are a lot more, appears to me at least, a lot more slips and trips, or they're carrying something, or they're walking the dog. Because we always look at the reason for the fall as well. And so I think it's very intriguing, and I'm sure there are some who are get dizzy, and we don't know exactly why, but I wouldn't say that was the preponderance of reasons, at least in the studies that we've done. And I don't know, Morton, if you have a different view on that.
I completely agree, Kate. It isn't something that you see that often when you see how did it actually happen this fall. It's not what they report. It's slipping or tripping or stumbling or something. And also when you look at the literature, and we looked at all these intervention studies, this is not something that is. It's not a focus area. Maybe it should be. But it's not at the moment, and I agree on Christine's comment that many physios might not be that familiar to this area. They're focused on balance, but is it a vestibular problem, or where is the problem actually? They might just notice, well, there's a balance problem, but there are specialists within this, and we might have to take those into to find out more about it when we have treatment of these patients. So yeah.
Thank you. So I have a few Q&As in here, which is exciting. I am going to go to M. Geerlings first, who says, hello, everybody. How can PT contribute to ensure that patients are evaluated and treated for osteoporosis when they are inpatients in the acute setting? I'm gonna open this up to the panel, but I just want to start by noting that we did, for these interprofessional areas, we did go to existing high quality clinical practice guidelines on those specific topics when they were available. So we did make a recommendation that physical therapists should contribute to interprofessional care to ensure that older adults with hip fracture are appropriately evaluated and treated for osteoporosis and risk of future fractures. That's our statement, but that isn't saying how to do it. And I think that's the thing about clinical practice guidelines, is that they deal with the existing evidence and provide recommendations, but don't tell you how to do it by and large. That's something that each health system needs to deal with. So I think one of the things I would bring to the panel is, can you explain your experiences in interacting, or your recommendations about interacting with the different health systems on osteoporosis for people with hip fracture?
Yeah, I might say that well, we are not the one evaluating or treating the osteoporosis, but just by asking patients, have you been evaluated, or are you under some kind of medication treatment for your osteoporosis, if you have one? That could just be our point of view, and we could take this into the interdisciplinary team and make sure that the right action is taken. So I think we can have this dialogue with the patients just like anyone else should have, and contribute to things happening related to this.
I would comment on that as well, but say I'm situated in a municipality, so it's the step beyond inpatient care. But when we look at records of patients, we do, at least in my place, we do attend to look at if there are some plans on like vitamin D supplementarians, and if not, asking the local GP to look into that area in order to get the things rolling.
It does seem like something like the frax tool, if you're all familiar with FRAX tool, might be something that we as physical therapists could begin to fill out. It might need other people on the team, but again, to start the conversation, the whole interprofessional management might be, there's no reason the physical therapist can't start that discussion.
Exactly.
And then from my perspective, I'm at University of Pittsburgh, and we do have a program that is inpatient that coordinates among and I'm not I'm not clinically treating inpatients. So this is what I know from my work with colleagues, but we have a fracture liaison service. And so when someone is as an inpatient and is fractured, that service is triggered internally based on, sort of automated procedures. But we have a full-time fracture liaison nurse and a whole service that gets initiated that is intraprofessional for identifying osteoporosis and, doing some shared decision-making with that person about management. So I think what I would say about that is that depending on where you're practicing inpatient care, you may have this kind of highly organized existing program that is interprofessional and is specific to this, or you may not. And so I think people have to know that this is an issue and be aware of it. And as physical therapists, if you don't have an actual program in place, dialogue with your other team members and as appropriate, patients would be a good place to start. M. Geerlings is saying, yes, thank you for your answers. We also have a fracture liaison service, but especially patients with hip fracture, they don't show at the fracture liaison service. So I think that this is another good point, is really how do people get identified? And I think that's an area for physical therapists to be hopefully voicing their knowledge of the care process, and they can be critical contributors to how people are identified and brought into the system. So I hope that helps. I'm going to move on to the next question, which is from Thomas Linding Jakobsen, and it says structured exercise rehab program is essential, including many different modalities post-operative. Do we know anything about compliance? Now, I don't want to put you on a spot, Kate, but I'm thinking all of these panel members have something to say about compliance, and I'm certainly happy to jump in, but I'm going to let you all talk a little bit if you'd like.
All right, I will start. We just published a paper in the Physical Therapy Journal. I think it's in the pre-print phase right now, that's looking at adherence to the exercise program. And this was in a randomized controlled trial, not in clinical practice. And we did find that people who really did adhere did better. But you are absolutely correct. It's a great point. We really, in clinical practice, we don't have any measures of adherence, really, if you'd have to look through individual charts. And in research studies, it's very undocumented. It's relatively, it's just, did they have the session, not what was done in the session. And there's a big difference there, because we know that if we are prescribing high intensity strength training, not everyone does the high intensity. If we're prescribing aerobic training, what's the intensity? So all of these things are, I think this is all uncharted, and I'm hoping, at least PTJ seems to be really interested right now in starting to make sure that researchers document adherence or compliance to exercise regimens.
Others, anybody have more to say on compliance or adherence?
Would you say something, Jan?
Yeah, well, we did a study on RCT, which is not published yet, but we found that, of course, these patients were high-level functioning patients before fracture, so gives them another starting point than those with a low functional level. But we saw that out of 100, 74 completed the study, the program, which consisted of 2 times a week of physical therapy or structured exercise with strength training. And out of those 74 patients, 80% attended all sessions. So, which is a high number, I think, but it's a selected group, I know. But still, it indicates that there's a good compliance, especially within those who are at a high level of functioning before fracture.
Thank you, Jan. I can tell you also there are there is an ongoing study right now in hip fracture that is working really hard to identify adherence right down to kind of the level of effort, intensity, frequency, and repetitions. So On the clinical trial side, I think there's progress being made, although what we saw for this clinical practice guideline was, very, very little in that area. So it's a big area for improvement, as Kate said. Thank you. I'm going to go to the next one, which is there any recommendation for time span of post-acute rehabilitation post-acute rehabilitation should last? Also, the amount of physical therapy they should receive or PT intensity that should be provided. So this is for post-acute rehabilitation, which I think is going to be you, Kate. And also, I just want to note that we have our appendices, which describe some of that. Kate?
Yes, I think one of the challenges is, each health system has their own rules, especially in the States. And then when we look across the world, we see so many different standards. So, I remember talking to colleagues in Ireland, and basically once they're out of that first month or 6 weeks of therapy, that's all they have. They have no home-based. And so I think the way that we wrote the clinical practice guideline was that if there are still needs, extended physical therapy would really be beneficial. And so it depends on the person. And I can comment on Jan's study, those people start off better than our people end. So the patients in Denmark are so much higher functioning than they are in the United States. And so I think it's up to the therapist to decide. The practice guideline says as long as there are still needs, functional needs, and again, if we think about the level of participation in the ICF model, we should really be trying to get people back to that prior level of participation, not just walking across the room.
I could add a little to that. I think when looking at the literature, and there's also a systematic review on this, actually, when looking at studies that starts after the standard rehab, which is in some countries 2-3 months, it's this extended rehab when it's being offered. These patients actually keep on improving, and actually they improve more than control groups. So to me, this indicates that many of these patients, they are not being offered as much physical therapy rehabilitation that they would benefit from. So I think that there's a much larger potential that they actually get they're not being offered enough, because it's costly to have people in lifelong rehabilitation, but it might be the right solution for these patients. And they need somewhere to go. They are not that good on self-training or exercises on their own when you look at the broader group of these patients. So yeah, but a specific time point is difficult, but there's probably much larger potential that they actually are given the opportunity to apply to.
Right, and I think the only thing I would add is that essentially I think we saw a very broad range of when people usually end physical therapy. And it could be from a small number of weeks, 4 to 6 weeks, up to 12-ish, weeks when they usually end. And the studies that were showing effects for what was called extended rehabilitation usually started at about 16 weeks afterwards, 4 months afterwards. Does that sound okay, Morten?
Yeah, exactly.
So that gives you just a sense of where everybody is at, and where those studies were. Here's one that says, and you all can jump in or I can take this. It says, any qualitative research on what kind of rehabilitation or physical activities patients with hip fracture prefer post-operative? So, I just would start by saying for this clinical practice guideline, because the world of hip fracture evidence and literature is so large, we focused on clinical trials and systematic reviews for interventions. So it wasn't our focus to look at qualitative research. And so that means that we didn't look through all of the qualitative research and report on it for this. Does anybody have any things they would add outside of that?
Yeah,
go ahead.
Yeah, I could. It wasn't like a qualitative research study, but I know from patients doing this strength training in the acute hospital, and also in the community that I heard of, that they actually like the progressive strength training because they could feel that this is something that really challenged my muscle, and they felt this muscle soreness, which was a positive thing because it indicated that they had trained with the right progression and intensity. So they actually liked that, that they could feel that this does something to my muscles. So, but otherwise, I'm not familiar with that, and we didn't look that much into it.
Yeah.
I can't cite any, but I know there is actually quite a bit of qualitative research that looks at patients' experiences after hip fracture and some of their preferences. Because I usually have students read those kinds of things to help them understand the person, not just the bigger picture. So I know it exists, but we did not include it.
Yeah.
I think there's some research by Maureen Ash, right, from Canada. I think she did some on that topic.
Thank you.
Yeah.
Okay, I need to wrap up our Q&A, but I am actually going to extend us at like a 30 seconds because we only have one more question to address here. And this is for Jan and Morten. It says, do you sometimes use the functional ambulation score instead of the cumulated ambulation score? And then we'll wrap up.
Yeah, and well, I should be able to answer that, but unfortunately, I can't completely what the functional ambulation score, the difference between that one and the accumulated ambulation score. I'm not. I can't say that exactly. So it's difficult to answer that specifically. But I would say you're most welcome to write me. And we can take up this discussion. My email is in the guideline, so I would be happy to take on this discussion after the webinar. So yeah.
Thank you very much. Thank you all for your wonderful questions. It's been really nice to have the opportunity to address them. I'd like to turn it over to Kate Mangione to close us out with a few thoughts.
I just do want to thank everyone again for their participation on behalf of the Academy of Orthopedic Physical Therapy and the Academy of Geriatric Physical Therapy and the FFN. I think that these guidelines were really different than many because we did look across the continuum of care, which all of us know is quite the journey for most of the patients post-hip fracture. They go it's a long process. We did highlight level 1 grade A evidence, which really supported that structure exercise. But I also call your attention to the fact that we included grade F expert opinions that this interprofessional management is absolutely essential in quality care for older adults. I think our recommended measures were very targeted and reflect the realities of patients post-hip fracture, and they span the ICF model, or you can use the biopsychosocial model, if you will. And so we have some impairment measures of knee pain and verbal rating of pain, but we have our performance measures of gait speed and the CAS and tug. But, knowing that this is a traumatic event, we think about falls efficacy and really think about the FESI. And most importantly, and again, maybe this because it's not done so much in the United States, but the new mobility score to really think about prior level of function and getting people back to that prior level of function and using that kind of score across the continuum will be some kind of measure, hopefully, that we can do. So again, thank you. And I want to thank our spectacular team that you see here. Tom, thanks for getting in here with us. We had a wonderful time working, and we look forward to your comments, continued comments and questions. Thanks.